This webinar will provide participants with an overview of a practitioner's guide for advancing health equity, community strategies for preventing chronic disease, also known as the Practitioner's Health Equity Guide. The webinar will highlight community examples of health equity integration in tobacco-free living and healthy eating strategies. Participants will also learn how implementing strategies for both general and vulnerable population groups benefits health outcomes for all. These presentations are designed to ignite ideas on how to effectively advance and sustain health equity efforts and improve health outcomes. By the end of the webinar, awardees are expected to be able to understand federal to identify at least one foundational skill of public health strategy and at least 2 priority strategies discussed in the Practitioner's Health Equity Guide, describe the concept of tailoring the Practitioner's Health Equity Guide strategies to the health needs of both general and vulnerable population groups, and apply approaches for improving sustainability of local health equity-focused activities. I would now like to introduce our presenters. Our first presenter is Pattie Tucker. Pattie is the Acting Associate Director for Health Equity in the CDC National Center for Chronic Disease Prevention and Health Promotion, Division of Community Health. She has more than 25 years of public health experience working with vulnerable groups in need of services and care provided at state and local health departments and a large public hospital. She has authored peer-reviewed publications, MMWRs, and book chapters addressing health disparities in vulnerable populations. Next, we will hear from Nina Ichikawa. Nina is the Program Manager for the National Asian Pacific Network to Eliminate Health Disparities, a program of Asian Pacific Partners for Empowerment, Advocacy, and Leadership. She is a former staffer at the U.S. Department of Agriculture's Know Your Farmer, Know Your Food program, and her writings on food policy and Asian American community have been published in Hyphen Magazine, Rafu Shimpo, Civil Eats, and Grist. We will then hear from Julie Deerinwater-Anderson. Julie is currently a program manager for the Cherokee Nation Community Health Promotion Program and serves as the project coordinator for the Community Transformation Grant Small Communities program. She has been with the Cherokee Nation Health Services for 16 years, working on a variety of public health programs focusing on the promotion of physical activity, healthy eating, and tobacco prevention. Julie is from Tahlequah, Oklahoma, and is a proud citizen of the Cherokee Nation. Last but not least, we will hear from Michelle Caruso. Michelle is a registered dietitian with her master's in public health from the University of Texas Health Science Center in Houston. She currently works as a health planner with the Community Transformation Initiative at the Houston Department of Health and Human Services. Both personally and professionally, she seeks to make healthy choices easier for all Houstonians. Thank you all for serving as presenters on our webinar. We are excited to have you. At this time, I would like to welcome Pattie to get us started.
So I'd like to also extend acknowledgments and thanks to those in the Department of Health and Human Services and to our many partners and contractors and subcontractors. Here in the Division of Community Health, our core principles are to maximize health impact by funding, training, and providing technical assistance to help communities build health local capacity, by advancing health equity and reducing health disparities by supporting initiatives that are improving opportunities for health in communities experiencing the greatest chronic disease burden, and use and expand the evidence base by compiling what DCH is learning as well as what is being learned by our awardees and partners and sharing it with community.
All right, at this time we're going to have our first poll question. So I'm going to read the question and then you'll be able to see the poll. Health equity means that every person has an opportunity to reach their full health potential regardless of, and you can select all that apply on this poll. Great, so it looks like you guys got the right answer. Pattie, I'll turn it back over to you.
Okay, and you're right. Health equity means that everyone has an opportunity to reach their full health potential regardless of one's characteristics or social position. DCH, or the Division of Community Health Initiatives, promotes sustainable community actions. One of our initiatives is the Community Transformation Grant, which supports state and local government agencies, tribes, territories, nonprofits, and communities across the country. All of the 107 awardees are working to improve the health of the nation with strategies that are focused on tobacco-free living, active living, and healthy eating, clinical and community preventive services to prevent and control high blood pressure and high cholesterol. During today's webinar, you will hear from two of our awardees, Michelle Caruso with the Houston Department of Health and Human Services, one of our capacity building awardees, and Julie Deerinwater-Anderson with Cherokee Nation, a small community awardee. Another DCH initiative is our Racial and Ethnic Approaches to Community Health program, which engages national organizations, community-based organizations, and local government agencies that are implementing and supporting the implementation of community-based programs that are culturally appropriate, with culturally appropriate interventions across the nation to eliminate health disparities among African Americans, American Indians, Hispanic, Latinos, Asians, Alaskan Natives, and Pacific Islanders. During today's webinar, you will also hear from Nina with the Asian Pacific Partners in Empowerment, Advocacy, and Leadership Organization, Ichikawa, I'm sorry. Through the Racial and Ethnic Approaches to Community Health, our REACH and CTG initiatives, DCH initiatives are building momentum for healthy behaviors where people across the U.S. live, learn, work, and play. By promoting good health for all requires partnership approaches, which includes creating a new and maintaining existing traditional and non-traditional partnerships across multiple sectors. By bringing everyone to the table, it brings their unique skill sets, expertise, and points of view to the mix. It also creates a win-win scenario and opportunities for leveraging resources. In addition, it generates the buy-in and support that's needed and critical for sustaining these changes. Multi-sector approaches may include partners from agriculture, urban and planning, and building environments, education, transportation, the business sector, commerce, and much more. And many of these sectors are already making decisions in areas that are important for public health, and they may or may not know it. As DCH awardees implement strategies, they are also looking at ways to maximize the impact of the strategy. So instead of implementing an intervention in one setting, such as a school or in a multi-housing unit or in a healthcare system, awardees are implementing interventions so that a large number of individuals are potentially exposed to the interventions in multiple settings. However, oftentimes in public health, there is an approach to either achieve population-wide impact or to reduce disparities. And in taking either of these approaches, there are two separate goals. However, through the HHS Action Plan to Reduce Racial and Ethnic Health Disparities, one goal is to advance the health, safety, and well-being of the American people. And some of the actions required to achieve this, to accomplish this goal, is implementing both what is universal and targeted interventions. In the Division of Community Health, we have adopted what is called the twin approach, and awardees are investing resources in broad population-wide interventions, while at the same time they're investing resources in targeted interventions to either reduce or eliminate health disparities in groups that are experiencing the greatest health burden. And today, one of our panelists, Ms. Julie Deerinwater-Anderson, will talk about how Cherokee Nation will describe how the twin approach is put into action. We recognize at CDC the need for practice-based tools with evidence-based policy system and environmental improvements that keep health equity in mind. And in response, the Division of Community Health led the development of a practitioner's guide for advancing health equity, community strategies for preventing chronic disease. I'll refer to it as the Practitioner's Health Equity Guide. It's has 4 sections. It is an online-based tool. And in Section 1, it's organized. It includes what we call foundational skills. These skills are listed. The strategies include around building the organizational capacity, engaging community members, developing partnerships and coalition, and up to identifying or conducting the evaluation. In Section 2 of the guide, it includes 4 strategies, 3 of which are priorities for the Community Transformation Grants. Section 2 is focused on tobacco-free living strategies. And this is an example. In each of the sections, 2 through 4, there are community examples of how communities are actually putting this in, the health equity into practice and advancing health equity. In this example, the community describes how partnerships with the local health department and others lead to smoke-free protection for over 350,000 residents and commuters in Jefferson County, Alabama. In Section 3 of the Health Equity Guide, there are 5 strategies focused on healthy food and beverage, and 2 are priority strategies for the Community Transformation Grants. And then in Section 4 of the Health Equity Guide, it's focused on acting living strategies. Of the 6 strategies listed here, 3 are priorities for community transformation, or CTG grants. In addition to the number of community examples, the strategies that are listed in the 3 sections, there are appendices in the Health Equity Guide. The first appendix, Appendix A, describes the chronic disease risk factors for over 8 different population groups. The Appendix B provides a list of potential barriers and unintended consequences, as well as questions one might consider or answer to ensure the design and implementation of a strategy and that it does not inadvertently widen health disparities. Appendix C include examples of online resources, or in fact 12 online resources, to assist with identifying and understanding health inequities in your area. One in particular is the Community Commons online resource or website, which has a tool, the Vulnerable Population Footprint. This tool can be used to quickly identify geographic areas of vulnerability within a community, vulnerabilities such as poverty, education, and so forth. And then the next or the final appendix in the Health Equity Guide is what we refer to as the Health Equity Checklist. The checklist includes 4 steps and a series of questions for consideration when designing a strategy to ensure that health equity is central to implementing an initiative.
So now we're going to have our second poll question. The question is, identify the term below that best describes an approach for implementing a strategy that includes both population-wide interventions designed with health equity in mind, as well as targeted interventions to address groups experiencing the greatest health burden.
Yep, if you're right. It is the twin approach. And again, that's an approach where you're implementing strategies that are population-wide, although you're keeping health equity in mind, but at the same time you're creating or intervening or using targeted interventions that are for a population who has the greatest health burden. Thank you.
So right now we are going to turn it over to Nina from Appeal. And Nina, you can go ahead and get started.
Thank you. My name is Nina F. Ichikawa, and I work for Asian Pacific Partners for Empowerment, Advocacy, and Leadership. We are a nationwide organization, and we're very grateful to be included on this webinar today. We will be talking about our work, which is mainly focused on foundational skills of public health, which are described in the Practitioner's Guide to Health Equity. This shows our network map, which, as you can see, is across the 50 states as well as on the Pacific Islands. Our current network consists of over 600 members across 44 U.S. states and 6 Pacific Island territories and jurisdictions. It includes community-based organizations, clinics, coalitions, state and local health departments, hospitals, federal agencies, foundations, academic institutions, and faith-based groups in both rural and urban areas. We, 5 years ago, we received a Racial and Ethnic Approaches to Community Health, a minority serving national organization grant, which enabled us to establish the National Asian American and Pacific Islander Network to eliminate health disparities, also known as NAPNEHD. Our goal in this network is to use our network to build foundational skills to eliminate health disparities in diverse Asian American and NHPI communities. And I'm going to talk in this webinar a little bit more about what those strategies are. Just as an overview of our presentation today, I want to give a little bit of background on our organization and as well as the challenges in addressing cardiovascular disease within our community. The prevalence of cardiovascular disease was chosen as the focus of this network. And then we'll go on to talk about our network approach to building community capacity. We're going to talk a little bit more in depth about each of our partners in both rural and urban areas and how we're looking forward to the next steps of this network. Just to give you all a little bit of context of CVD or cardiovascular disease among Asian American, Native Hawaiian, and Pacific Islanders, it is now found to be one of the leading causes of deaths among AANHPIs, leading to 1 in 4 deaths. In 2007, it accounted for 1 in 4 deaths. And we've also found that the aggregate data shows obesity prevalence is generally low for Asian American population when the data is all put together. But when data is disaggregated and broken down, as you can see in this slide, to say Samoan, Filipino, Japanese, Asian Indians, we find actually exceptionally high rates of CVD. And this has been a long-time concern in this community, and we're devoted to changing this norm as quickly as possible. In the nations of the Pacific, which are in free association with the United States, we find some of the highest obesity rates. As you can see from this slide, Pacific Island nations make up 8 of the 10 most obese countries globally. And that's why we've also focused special attention on this region. They also send migrants to the United States, and there's a cultural chain connecting many countries in the Pacific, and we're devoted to reducing cardiovascular disease among those underserved communities. Despite these challenges, we often, and the reason this network was created is we would like to counteract some of the misconceptions or stereotypes that are preventing this community from always receiving the most efficient assistance. Among these challenges, in 1996, CDC Office of Smoking and Health report found that Asian American and Pacific Islanders were found to have a low to very low capacity to conduct research, develop infrastructure, create and manage programs, and develop policy initiatives on tobacco control. We've extrapolated this information to cardiovascular disease, and we're aiming to increase community capacity to push for evidence-based system change. Also, as you can see from the first bullet point, there is a model minority stereotype that perhaps members of our community do not need any assistance, and this is a stereotype we're working hard to reverse. Of course, language access for newer immigrant parts of our community. Language access is a very serious barrier. And as I mentioned earlier, both intra-ethnic diversity and data aggregation is preventing sometimes local officials and local health providers from understanding the varied needs within this community. As you can see, this is our logic model and also the way that we conduct all of our work. As you can see, there are multiple steps leading to the goal of policy systems and environmental change to lower CVD rates in Asian American, Native Hawaiian, Pacific Islander communities. Things like community participation, learning how to use and communicate data, and building up homegrown leaderships are just a few of the foundational skills that we have found to have proven results in altering the food and physical activity environments. And this lists the objectives, which I won't read all the way through, of our network to eliminate health disparities. Feel free to look on our website, appealforcommunities.org, or on the webpage of the REACH program through CDC to learn more about our specific strategies. When we began this network, we were working with 3 local affiliates. In Seattle, Washington, a group called APICAT, which had key informants in 7 communities: Cambodian, Chinese, Filipino, Korean, Lao, Samoan, and Vietnamese, who are expressing a lack of language-specific and culturally appropriate health materials. In New York City, Coalition of Asian American Children and Families, and in Palau, the Coalition for Tobacco-Free Palau. These three groups enabled us to reach local communities with their homegrown expertise and networks. And this next slide illustrates what those networks are. I know it looks pretty complicated, but we just wanted to give a view of the power of the network and the constellation of smaller local groups that we were able to reach by going through local coalitions. Since then, they've actually grown to many more groups. And you can just get a little bit of a sense of the diversity of people that we're trying to reach and all the challenges that come with that. And just to get into a little bit more detail here, Coalition for Asian American Children and Families established APA HEALIN, Asian Pacific American Healthy Eating, Active Living in Our Neighborhoods group. Through this program, they were able to do a photo voice assessment and disseminate results and put out a wonderful report called Planting Seeds of Change. They also supported 4 successful play streets in largely Asian American and immigrant neighborhoods in Queens, which are reaching, enabling the healthy eating, active living movement to reach new audiences and in new languages. All the way out on the Pacific Islands in Palau, their work has been very impressive in terms of installing Share the Road signs along the national road, which previously did not have a significant walking area or knowledge of walking protocols among many drivers. Also, they've conducted community-wide education, not only within their island, but across the Pacific Islands, where there's a lot of communication across islands. On to our next slide. Through our dissemination efforts, nearly 700,000 individuals have been reached in 3 geographic areas: the Republic of Palau, New York City, and in Washington State. We use both online, social media, and in-person meetings in order to share the results and to also learn from our community partners. Looking to the future, we are working on many plans to keep this program going after this initial grant is over. Our HEAL subcommittee, which meets regularly, will continue to meet. We also are constantly sharing funding opportunities with our affiliates. And most importantly, we feel that our coalition partners are now part of this HEAL movement and have been empowered to participate in local and national efforts to improve their cardiovascular health environment. We'd also like to invite everyone to our 20th anniversary conference on tobacco, cancer, and obesity disparities affecting Asian American, Native Hawaiians, and Pacific Islanders on September 24th through 26th in San Francisco. We'll be sharing critical data and best practices from around the country, and would love to hear from you as well. In terms of lesson learned, we are now actively trying to share these, including our first one is that we really have a need to develop and fund comprehensive AANHPI HEAL research agenda to assess the food environment and built environment for these communities. We also need to fund the replication of culturally competent model public health initiatives for these communities, including capacity building initiatives. We see a need to increase the representation of AANHPIs on key national and regional decision-making bodies. And we need to continue to educate these communities about corporate accountability and the role of tobacco companies, fast food, processed food, and other environmental factors that are affecting cardiovascular health. If you'd like to receive more information, we really welcome you to download these two documents that go along with this webinar. There's a policy framework that lists our policy goals in this area. That's the first download. And the second one is a fact sheet with a lot more details and research links. It's called Tobacco and Obesity Disparities as Social Justice Issues. These are both available for download in the resources and publications part of our website. And finally, please keep in touch with us. On our website, you can sign up to receive regular email updates. We also have a Facebook page and a Twitter page. And we just want to continue the discussion with everyone how we can work together to eliminate health disparities and reduce cardiovascular disease among all Americans. Thank you so much.
Thank you, Nina. Right now we're going to turn it over to Julie from Cherokee Nation Health Services. And Julie, you can go ahead and get started.
Great. Thank you, Anna, and hello, everyone. I would like to thank CDC for the opportunity to be a part of today's webinar, and I will be providing a tribal perspective of why Cherokee Nation is focused on tobacco-free living and how we integrate health equity into a tobacco-free living strategy. Okay. So I'll start off with a brief overview about Cherokee Nation Health Services. We are the largest tribally operated healthcare system in the U.S., providing healthcare services as well as public health programs. And our mission is focused on advancing the health and quality of life among our communities and families. We are a Community Transformation Grant Small Communities Awardee, and my presentation will address Section 2 of the Practitioner's Guide, Maximizing Tobacco-Free Living Strategies to Advance Health Equity. And to provide an understanding about Cherokee Nation and our communities, I'll talk a little bit about our demographics and some of our health disparities we face. I will provide an example of our tobacco-free living strategy, smoke-free parks, and how we integrate health equity. And I'll conclude with some of our successes, lessons learned, and our next steps. And so to give you a little more idea of where we're located, the geographical area of the Cherokee Nation includes all or parts of 14 counties in northeastern Oklahoma. Our tribal jurisdiction is over 7,000 square miles, and the majority of our communities we serve are located in rural areas. Our tribal headquarters is located in Tahlequah, Oklahoma, and this is where our tribal governmental processes take place. So when looking at our population, Cherokee Nation is the second largest tribe in the U.S. with more than 300,000 citizens, of which nearly 63% reside within our tribal boundaries in Oklahoma. Because Cherokee Nation doesn't reside within reservation boundaries, our tribal citizens are dispersed throughout our service area, and our interventions have the potential to reach not only tribal citizens, but those living in this area. Because Cherokee Nation is a sovereign nation, we also must work within a mix of local, state, tribal, and federal laws. Our CTG intervention target area includes the Cherokee Nation 14-county service area and a focus on 4 major county hubs, Cherokee, Adair, Mays, and Nowata counties. And if you can locate these on this map, these counties have some of the higher population of American Indians. So as we take a look at key health factors, we find differences here in the Cherokee Nation. This table highlights some of the health disparities of our American Indian population. And as you can see, American Indians living in the Cherokee Nation area have higher rates and many different health factors as compared to the U.S. general population. When we look at more local level data for health outcomes, which is limited on available Cherokee-specific data, we see that the leading cause of death in American Indians in the Cherokee Nation are related to the same chronic diseases that are impacting the state of Oklahoma as well as the nation. We feel the root causes of our greatest health challenges in the Cherokee Nation are from tobacco use, poor nutrition, and lack of physical activity. But this chart pinpoints what American Indians in the Cherokee Nation are dying from. But we can also utilize this data to highlight that along with the loss of our people from preventable chronic diseases is the loss of knowledge about our culture, traditions, and language that will not be passed down to our future generations. So promoting and supporting healthy families and communities is a cultural value of the Cherokee Nation, and public health and prevention programs are viewed as a priority for our people. Our prevention priorities include developing opportunities for our communities to be more physically active, eat healthy foods, and be tobacco-free. And we strive to work together with communities to make healthier options the easiest choices for all people. So why tobacco-free living? As we take into account healthy factors and health outcomes related to tobacco-free living for the Cherokee Nation, available data shows that smoking rates of Oklahomans, Oklahoma Native Americans, and Cherokees living in our jurisdictional area continue to be higher than the national average. We also know that lung cancer is the third leading cause of death among Cherokees. We are currently implementing a tribal health assessment and the American Indian Adult Tobacco Survey to identify exactly why this is the case. But this data suggests that there's a huge opportunity to address health disparities through tobacco-free living strategies. So tobacco-free parks have the potential to be a high-impact strategy because there are such high rates of smoking among the general population, Native Americans in our jurisdictional area, and we also see high rates of smoking among Native American high school students. We have selected a strategy that has the potential to reach all residents at the county level, but we also identified the vulnerable population experiencing the greatest health burden, Native American youth and adults. So our approach included these activities listed, and in the following slides I will highlight some of the key factors that help address health equity in the design and implementation of our tobacco-free park strategy. So one key factor that we considered in our tobacco-free park selection of strategy was existing capacity and infrastructure. Cherokee Nation served as the lead agency for this step. Cherokee Nation's health services function similar to a small state Department of Health for counties within our jurisdiction. And this is because often our state health department is located 3 hours away. And so sometimes prevention services from the state health department don't reach our side of northeastern Oklahoma. So Cherokee Nation in our area is looked at as the leader of prevention, and so we served as the lead agency for the strategy. We also identified 4 existing county coalitions that were also working on healthy community goals and objectives. And working with these existing coalitions helped to expand and enhance resources such as dedicated staff to work on the process, office supplies, meeting space, development of education, awareness materials, and development of signage. To ensure community awareness and involvement, the coalitions formed tobacco-free park subcommittees that focus on planning and coordinating the local tobacco-free process. The subcommittees represented different sectors from the community and included members that actually lived or worked in the community. This helped to provide firsthand knowledge of social norms, such as how the community views smoking and secondhand smoke. The members of the subcommittee included people from the general population as well as Cherokee Nation citizens, such as students working against tobacco youth members and tribal health educators. SWAT members are part of student teams working on tobacco-free environments for their schools. And our tribal health educators are similar to community health representatives who work out in the communities and serve as the liaison between community health programs and the communities themselves. And most of our tribal health educators come from the communities where they work. We also engaged partners in the review of local data by taking inventory of what tobacco-free indoor and outdoor policies already existed. Our communities found that many school campuses, businesses, and restaurants had tobacco-free policies in place. There were also examples from other cities across the state of Oklahoma that had successfully implemented tobacco-free park policies. This data provided the awareness that the communities needed to agree that tobacco-free parks promotes a consistent health message for youth as well as the general population. Our partners were provided technical assistance and training on presenting education and awareness of the benefits of tobacco-free environments during these three main points of implementation, from meeting with local city officials to providing technical assistance on drafting voluntary tobacco-free policies, and also providing technical assistance in the evaluation of the tobacco-free process. So we use culturally appropriate media and education efforts to build awareness of health effects of smoking and secondhand smoke exposure in the Cherokee Nation. Media efforts targeted our priority population, which were American Indian youth and adults, but we shared through various media mechanisms that reached the general population. For social media, we utilized Facebook, Twitter, tribal, and our local coalition websites. We also used community billboards, local newspaper ads and newspaper releases, and local radio spots. So when developing media messages, and we take into account what is accessible by the general population, as well as Cherokee cultural beliefs, this is an example of how we have incorporated the Cherokee language into the Oklahoma statewide Tobacco Stops With Me awareness campaign. This helps to keep our messaging consistent with the state health message, but also culturally appropriate for our communities. This is another example of a tobacco-free parks awareness ad that we developed, and where we have incorporated Cherokee Nation's identity with the Cherokee language and our tribal seal, along with our partner's logo and the Oklahoma Tobacco Quit Line information. Because Cherokee Nation has such a strong presence among our communities, the general population is pretty familiar with seeing and hearing about Cherokee culture and language, as well as staying up to date with current tribal events. So this makes our messaging accessible to both Cherokee citizens as well as the community at large. So as Pattie mentioned in her presentation, the twin approach is the idea that you're implementing population-wide interventions with health equity in mind, while tailoring certain interventions to address groups experiencing the greatest health need. Because Cherokee Nation citizens are not on a reservation and live among non-tribal citizens, many of our strategies are essentially examples of the twin approach. For the tobacco-free park strategy, reducing the secondhand smoke exposure of the general population through tobacco-free parks is an intervention that reaches the entire population. But we tailor the intervention with culturally appropriate media messaging and include members on our subcommittee who can ensure that each intervention resonates and fits with their specific community. And of course, we could not do this work alone, and we are fortunate to have many partners that have been involved in our community transformation grant efforts. Our partners meet on a monthly basis to review progress of strategies being implemented. And these partnerships have really brought people of the community together, such as law enforcement, school administrators, parents, city leaders, and youth. People who don't normally get together to talk about ways to implement strategies like tobacco-free parks, which can make a difference for their community. Because of the community members' efforts, tobacco-free parks are becoming a norm in our area and reaching other communities throughout the Cherokee Nation. To date, there are 10 cities and towns located in the Cherokee Nation area that provide access to tobacco-free public parks. So some of the lessons we've learned, implementing a tobacco-free park strategy wouldn't look very different for a non-tribal community, but you would want to cater your approach to vulnerable populations within your community. The key components we found were to use the existing capacity and infrastructure that is already present in your community and to include key stakeholders so that strategies can be tailored. We also think it's important to educate stakeholders and community leaders, as well as the general population, about risks associated with tobacco use and exposure to secondhand smoke. Some of our next steps include continuing to build the evidence base with conducting tribal health assessments to understand better why our smoking rates are so high. We also are working with our coalitions to develop digital stories to share local successes. We are assisting communities with enforcement activities. We provide mentorship to other communities that are interested in implementing similar strategies. And we are working to identify other potential funding sources and opportunities to help with sustainability efforts. And this concludes my presentation. I would like to say thank you for letting me share our perspective with you today. And if you'd like to learn more about us, there's information on how to contact us. Thank you.
Thank you so much, Julie. Our last presenter is going to be Michelle from Houston. And Michelle, you can go ahead and take it away.
Thank you, Anna, and good afternoon, everyone. Thank you for the opportunity to present today. I've really enjoyed hearing my co-presenters, and I think what we have to talk about today in regards to Houston really builds upon some of the other topics that have been discussed. So my name is Michelle Caruso. I'm a health planner for the Houston Department of Health and Human Services, and today my presentation will go over a strategy related to Section 3 of the Advancing Health Equity Guide. So a quick overview of our team. We're housed in the Health Planning, Evaluation, and Program Development Division of the Houston Department of Health and Human Services. And we are a community transformation grant capacity building grantee for large cities or cities over 500,000 residents. We also work under the heading or brand Go Healthy Houston, which is the Mayor's Task Force for Obesity Prevention. And it's also the brand that Community Transformation in Houston is using for sustainability purposes. And I also want to note before we get started that as a capacity building grantee, our team is not funded to implement initiatives or strategies, but instead we're tasked with building partnerships and collaborations around key ideas and initiatives. So today I'll really be speaking from that lens related to the initiative we're going to address. A quick overview of our presentation. I'll go over a community profile of Houston, Texas, and we'll talk about how needs were identified for these vulnerable populations. We'll then discuss the strategy selection implementation of a healthy food financing initiative, which was recently implemented within Houston. We'll talk a little bit about barriers for this initiative and successes related to health equity, and then we'll talk briefly about additional resources that are available around this strategy. So Houston, Texas is actually the 4th largest city in the United States with about 2.2 million people as of 2012. And it's, the population is urban, but it's spread out over 600 miles, so it's a very wide-ranging city. The median household income is $44,000 per year, and 22% of our population lives below the poverty level. So according to the Kinder Institute for Urban Research at Rice University, Houston is actually ranked as the most diverse metropolitan area in the United States. So it's even more diverse than places like Oakland or Los Angeles, or places that we would think of as being very diverse. And Houston's also a majority minority city, which is expected to be the case for most major cities in the near future. Of our 2.2 million people, 44% of this population is Hispanic or Latino, 26% white, 24% African American, 6% Asian, and 46% of Houstonians speak a language other than English at home, compared with 36% of Texans and 20% of people in the United States. That's a very high rate. So those are the demographic numbers for Houston, but health inequities in Houston are not really a direct result of this diversity. They really result from a long-standing history of development patterns, which have resulted in a variety of inequities, including inequities due to health. Houston's high level of diversity just makes addressing these health inequities even more complex, as we'll see on the next few slides. So this is a map of Harris County, which is the county in which the city of Houston is located. Harris County's population is actually almost double the city of Houston at around 4.2 million residents. But what this map shows is population by primary racial or ethnic group, and it's overlaid with rates of poverty. So if you'll note, areas of the city and county that are majority minority, so they are the orange areas, the purple areas, and the green areas have higher rates of poverty. Also note that those majority minority areas have some of the highest poverty rates, and they're also spread very widely throughout the county. So this widespread area really makes it difficult to address health inequalities, and it makes the issue even more complex. So this next slide shows the percentage of residents over the age of 18 who are overweight or obese in Harris County. So this is actually split into 4 quartiles. Red shows the highest, the 25% of the population with the highest rates, followed by yellow, light blue, and then dark blue. And while overweight and obesity are definitely an issue across the city and county, there's definitely a higher burden in the majority minority areas that were shown in the previous map. So this would look similar even if we mapped other indicators of chronic disease or social determinants of health. And these same areas are also food desert areas within the county. So this is really important information for us to understand as we focus our chronic disease prevention efforts in Houston towards areas that would have the most benefit. So 2 reports came out in the same year, both in 2012, which identified grocery store growth in these food desert areas as an opportunity to impact vulnerable populations within Houston and Harris County. Our community transformation team within the City Health Department contracted with a local health equity expert to develop policy scan report with a health equity lens or framework from inception. So as the health department, we really develop a health assessment for the city every 2 years. So with this policy scan and this community transformation assessment, we really wanted to prioritize policies that would have the greatest impact on the most vulnerable Houstonians. And this was different than other reports or policy scans that had happened in the past and potentially more impactful. We feel like it's been definitely more impactful. So meanwhile, at the same time, the Food Trust, which is an organization out of Philadelphia, created a task force within Houston called the Houston Grocery Access Task Force, which looks specifically at grocery store access for low-income and vulnerable populations. And our team at Community Transformation and the City Health Department was a member of that task force. So both of these reports made a number of similar recommendations around access to healthy food, especially for low-income vulnerable populations in Houston. And this really allowed these issues to get on the radar of policymakers in Houston. It definitely set the tone. It fueled and heightened awareness, not only for those policymakers, but also for key stakeholders and organizations within these vulnerable groups. And the 2 reports also clearly showed that there were inequities in Houston related to environmental factors that can support healthy lifestyles, like access to healthy food. So one of the recommended strategies in both the Health Equity Policy Scan and the Grocery Development Report was the implementation of a fresh food financing initiative, which are sometimes also called healthy food financing initiatives. And these were really started in Pennsylvania and California. Those states are the initial models of these initiatives. And what a healthy food financing initiative is, it basically provides a low-interest loan and sometimes grant financing for food retail investment in these low to moderate income areas, especially in food desert areas. So it helps retailers overcome the higher initial barrier to entry into these communities. It also mandates, through receiving this loan funding, it mandates the availability of high-quality, healthy food within a certain percentage of the store, and typically it's 50% of the store must contain non-processed foods is the requirement. So healthy food financing initiatives are really a viable, effective, and economically sustainable solution to the problem of limited access to healthy foods, which was identified by the two reports. And these initiatives can definitely improve the health of families and children. They can also create jobs and stimulate local economic development in these low-income communities. So what happened next? Within Houston, capacity was built around these initiatives. There were meetings to disseminate the recommendations from those two reports among key stakeholders. An analysis of national best practices was provided to policymakers with a health equity lens. We also identified barriers to this type of policy, and we really worked in partnership. The key partners in this effort were very numerous. They included major grocery chains, grocery supply companies, and the Texas Retailers Association, city council members, various City of Houston departments, including the Housing and Community Development Department, the Planning Department, the Health and Human Services Department, and also the Mayor's Office. They also included many community-based organizations like Local Initiative Support Corporation, or LISC, Children at Risk, Recipe for Success, and the Houston Food Bank. And really, there were many more partners, including key stakeholders and residents within these food desert communities. So we worked hard also to identify barriers to this type of policy. And one barrier that really was identified as very inhibitory was actually an alcohol sale policy which prohibited alcohol sales that were within 1,000 feet of schools and 300 feet of churches. So many of these identified food desert areas in Houston have a higher concentration of churches and schools than other neighborhoods. And we also found that grocers have limited interest in these areas where basically they have limited interest in not selling beer and wine in these areas and opening just simply grocery stores, because without beer and wine sales, they were concerned about potential profit loss. So we found that there was an exemption passed in January after this barrier was identified, and now stores greater than 10,000 square feet are exempt from this policy. So large food retailers can develop in these communities moving forward. And actually the map pictured in this slide is a Google map of churches located within a notorious Houston food desert neighborhood called the 3rd Ward. And as you can see by all the red dots on the map, it would be difficult to find an area for a grocery store to locate within this neighborhood until this exemption was passed. So the major facilitators to implementing this initiative were finding access to funding. So we are one of the few cities in the U.S. with an initiative independent of the state. New Orleans is the other city I'm aware of with an independent initiative. And we were able to find funding through community development block grant funds through the U.S. Department of Housing and Urban Development. These were awarded to the City of Houston Housing and Community Development Department. There were numerous neighborhoods that we could identify as food deserts within Houston for this pilot store, which contained vulnerable populations. And we really wanted to ensure that the guidelines around this initiative supported increased health equity within these neighborhoods. So the Houston Department of Health and Human Services provided recommendations to policymakers and stakeholders based on national best practices. So we really wanted to identify best practices in terms of health equity, and not only related to making sure quality and healthy products were offered in abundance, but also things like considering location efficacy in terms of access to public transit, because we know that many of these vulnerable populations have less access to personal vehicles, and also making sure workforce development is an eligible expense for loan money to support increased employment of the workforce from these target neighborhoods. So the first pilot store has been funded in the 3rd Ward neighborhood that I identified in the map in the previous slides. And the 3rd Ward is a food desert near the heart of Houston. It's about 80% African American, and this neighborhood is known to have many health-related inequities. There's also very strong support in this neighborhood, very strong grassroots support for a grocery store in this community. And the funds were received by a local independent grocer, and currently the store is under development. So our next steps are really to evaluate the economic viability and health impact of this pilot store. We also want to refine the criteria based on this evaluation. We also need to have and continue having conversations with all of our major grocery chains on how we can further increase access in other neighborhoods. And then we need to work on obtaining future funding if the pilot is deemed successful. So the good thing about this initiative is that Houston developed a brick-and-mortar grocery store that is inherently sustainable. The community, this food desert community, now has greater access to healthy food options and now has a potentially healthier environment. But what we don't yet know is if this will impact the actual rates of disease or health outcomes in Houston and in this specific neighborhood. So just because the store is built doesn't automatically change the culture, and certainly we know that more work needs to be done, but we really feel this type of initiative is a good first step in decreasing health inequalities related to access to healthy food. So here are a list of additional resources if you would like to know more information on healthy food financing initiatives in other cities and states across the country, and I've also included links to our health equity assessment that we've done in Houston. And thank you. I really appreciate the opportunity to speak with you all today. Here's my contact information in case there are further questions.
Okay, thank you so much to Michelle and all of our presenters. We really appreciate all the hard work that you guys put into this. At this point, we are going to turn it back over to Pattie for a few closing remarks.
So I'd just like to ask the listeners to think about, as they think about or continue to advance the health equity, I encourage them to ensure the sustainability of their efforts by engaging the community early on in the ways that are meaningful, by building and expanding your partnerships, by working with an explicit intent toward health equity, and by using your evaluation to help with the understanding the effects of your efforts in addressing health inequities. If there are, I mentioned earlier about the Health Equity Guide. I want to reemphasize that it is an online tool, and we encourage you to visit the website, which you have in your handouts, and that if you would like to learn more about the Division of Community Health and the initiatives that are available to you, please visit our website. I want to thank the panelists as well as the participants, and thank you all for this opportunity to share this resource with you.
Thank you so much, Pattie, and to all of our panelists and to all of our audience members. That concludes our webinar for today. I hope you all have a great afternoon.